Welcome back for this week's episode of the Modern Pain Podcast. This week we're going to be talking to a friend and colleague, Laura Rathbone. Laura is an advanced practice physiotherapist working with people experiencing complex and persistent pain conditions and a consultant in physiotherapy for CRPS and neuropathic pain. As part of her work, she collaborates with clinicians to help develop their practice and reach their goals as a clinical coach, as well as through her group and community platforms like Pain Geeks and her own subscription. In this episode, we're going to talk a little bit further about her journey and some of the people who've impacted her along the way. We also talk about how she's resolved that conflict that arose for her, like for all of us, when the conception of pain she was taught in university didn't really line up well with the complexity of what she was seeing in the clinic. Laura discusses her strategies to deal with uncertainty she sees in the clinic and also the role philosophy plays in her thinking and practice. We're also going to touch a little bit upon psychologically informed practice and her past training and perspectives on how we can best use it in clinical practice. Acceptance and commitment therapy is another topic we discuss, and this is where Laura is an expert, in my opinion. She's leading the way on applying ACT in the clinic and helping other clinicians do the same in her coursework. It was great talking to Laura. I think you're all going to really get some significant value from this episode. Enjoy it.
This is the Modern Pain Podcast with Mark Cardula.
Welcome to the podcast, Laura.
Hi. Yeah, thanks for having me.
It is always good to chat with you. I've had the privilege of chatting with you a few times now. We've had you on when Jared and I were doing our Learning Academy, where we had you do a masterclass on ACT, and we'll probably touch a bit upon ACT because I know that informs a lot of what you do in the clinic. Yep. We'll also probably talk a little bit about your world in the clinic. You've also recently had a major win for yourself as far as finally getting licensure there in the Netherlands. That was a heck of a journey.
I won immigration now somehow.
Yeah. I remember talking, and we had chatted before this, that like 2 years ago when we had that masterclass, you were in the midst of it. And recently when I saw that, man, that took a bit, but we'll touch upon it.
Yes.
Hopefully not get the blood pressure too raised, because I know that was probably a frustrating journey as well.
But it has been an interesting journey. Sorry to interrupt you, just to say, like, registration equivalence across international borders is no small thing. And I think as physiotherapists working within a protected title, we don't necessarily realize just how hard that is. And of course, intersectional, when we apply intersectional theory, we know that it's not the same experience for everybody. And so it's really helpful for us to be mindful of that, but also to recognize that let's not take for granted the freedoms that we have to practice, and just how easily that can be taken away.
Yeah, definitely something to be grateful for. I've been around some clinicians who've come to the U.S. and, just from afar, I've seen like, man, that sounds like it's a pretty intense process. I don't know the exact ins and outs of it, but everybody I know that's done elsewhere who's traveled abroad has mentioned it's been a challenging process, to say the least. So congratulations on that for finally getting to the finish line.
Yeah.
For those of our audience who aren't aware of you, I know a lot of folks see you online and doing some amazing things, but I'd love if you could just kind of recount a little bit of your background and maybe your journey that brought you to where you're at.
Oh, yeah, sure. Well, I guess my clinical profession, I'm a physiotherapist, and I graduated, I think I finished my uni bachelor's about 12 years ago. And I've been sort of on this journey of trying to understand, what is not only like what is pain, but what is the role of a physiotherapist in somebody else's pain experience? And how do we draw on all the different and available therapeutic theories and frameworks in order to best support people that come into our clinic who we don't know, and we have to figure out how to get to know them and how to open up a safe space for that relationship. So I'm very interested in that and communication. And I guess that my love of like communication and relationship building and the sharing of information probably comes from like my early, I suppose, professional aspirations to be a writer and a journalist. And so I actually trained as a journalist before I trained as a physiotherapist. And so communication study and the sort of philosophy of language, these kind of things were part of how we understood the story and how we, how we understood what it was to have integrity in your writing and what it was to hold a relationship and to try to get to the important points of somebody's story. So that's where that came from. And then since then, I worked, most of my career, I worked in London, although I'm not from London. I'm from the northwest of England, from a very small seaside town called, well, it's not very small, actually. It's quite big, called Blackpool, which is on the beach. And it's mostly like well, I don't think Blackpool would like me to say this, but it's kind of like a party town. And so I had a great childhood. I had a great young adult life. And but then I moved down to London and mostly worked in different types of settings. So I started my practice in private physiotherapy, working mostly on like injury-based insurance cases, which was wonderful because I got to meet lots of people, but it wasn't so much fun because I was constantly feeling the conflict of my ethics. And that's challenging as a new grad, being able to navigate that is quite hard. There's a lot of pressure. And then after that, I went and worked embedded within a GP practice, which is like a physician, a general physician, I think you call it. And but that's obviously what we call it because it's GPs anyway. So general practice.
The same.
Yeah, I've just never thought about what the words might actually be. And then I worked there, which was really lovely. And I had a great relationship with the GPs in that department and saw a lot of their sort of chronic pain and ongoing musculoskeletal conditions patients, which was really wonderful because I got to establish relationships, which I like. And then I went and did my master's at King's College, where I did advanced neuromusculoskeletal physiotherapy practice, which is where we're looking at sort of advanced clinical reasoning in MSK conditions and applying, or I suppose the idea is to try and think across the neuromusculoskeletal systems when we're thinking about patients. And that's where I got to meet Professor Mick Thacker, who taught us our pain module. And so I was very lucky to have that experience. And then he introduced me even more into the world of thinking about pain through using different traditions like philosophy or humanities, and as well as, as well as like being able to integrate the IASP framework for understanding pain in a more sort of, I suppose, neuroscientifically based way. So an IASP is the International Association for the Study of Pain. So they set the sort of baseline curriculum for pain specialized clinicians. So I went and worked in, from the GP centres, I then went and worked in typical outpatients in the NHS, high volume again clinics. And then from there I went to tertiary care, so into the specialised pain system, working in St Thomas's Hospital in London on their inpatient 4-week pain management programme, which is one of the national centres for pain in the UK. And now I'm in Amsterdam, just kind of bringing this all together in my own way and trying to figure out, well, okay, after all of that experience, how do I want to practice? What practice do I want to build and grow and nurture that I think best reflects my integrity, my ethics, and my interpretation of the evidence? Thinking about the whole landscape of evidence, not just, these kind of like the hierarchy and, systematic reviews and the kind of positivist approach to science, but thinking about what, how do we honor the experience of each individual person, and the sort of the complexity of pain, and what kind of a practice would we build if we honored all of those things. And that's where I am now. Yeah.
It's a pretty amazing journey. I think, definitely jealous to have the opportunity to have Mick as your instructor. I've had the, privilege of having Mick, having a few chats with him, and he's been involved in a few things, and always come out so much better. Also come out scratching my head and thinking a lot more deeply after you chat with Mick. He just obviously is a very deep thinker and has definitely done similar as far as spurred my thoughts of looking a little bit deeper and looking at different perspectives of some of the knowledge we have in the world, as far as not just from that physio lens of expanding. I'd love to hear a little bit about the conflicts you've had as far as when you kind of considered pain. We come out of uni with a thought of it in a very kind of physio educational mindset, which I know in the US still getting better. I'm UK, I know from my discussions that they're working to improve it as well, but we probably have a way to go. But I'm just curious, your conflicts with your kind of conception of pain, not just when you left school, but how it's kind of progressed over time. I mean, I don't think we ever fully resolved that conflict. It's a very complex topic, but I'd love to hear what your journey's been with pain and how it's kind of changed over time.
Oh, that's such a good question. I guess I'm spending a lot of time thinking about it, but maybe not necessarily putting it all together in a timeline. So I spend a lot of time thinking, well, what do I think pain is now? Like, what do I understand about it now? But I did a talk recently where I was like, hey guys, before you went to university, you knew what pain was. You had a really good idea, a good working idea of what pain was that, made sense to you. And then we go to university and all of a sudden we're like, I have no idea what this thing is. Like, what is it? Like, I don't even know if people really experience it. Like, and we start thinking that we somehow have some role in judging somebody else's pain because it gets pulled apart and then we sort of struggle to put it back together again. And I don't know whether we ever really can, because pain just isn't that simple, But I guess, before I went into university, I knew what pain was. Pain hurt and it was scary. And, most of the time it was very helpful, but sometimes it was weird and didn't make any sense at all. And my mum had chronic low back pain. So I knew that sometimes it lasted longer than, some pains seemed to last for a very long time and some pains didn't. My dad was a much older father. He passed away 10 years ago, but he was an older gentleman. He just lived with pain every day. So I also had this idea that when we get older, it's just seems to be just part of life. Then I went into physio school and started getting all concerned with how I could prevent people from feeling pain and how I could cure their pain. And all of a sudden, somebody else's pain went from being this thing that seems to be just part of life to something I am personally responsible for eradicating. And that responsibility, I think I felt very, very deeply. And I think it became a part of my identity in some way as a clinician. I became very much like, I've got to be able to understand everybody's pain and find the cause and fix it. And I went on this really big journey into manual therapy because that seemed to be the right thing. And, needling and trigger points and, how do we do like muscle energy techniques and fascial release and all this stuff. I went into all of that with this idea that I was supposed to be getting rid of somebody else's pain. And then as I've emerged from that journey and become more interested in, well, not what works for pain, but why does somebody have pain? Like why for this person does pain seem to be so, I suppose, without wanting to be too dramatic, but why for this person is pain such an invasive experience, so distressing, so disabling, but yet we can't find anything? Like, why is this happening? And that question just took me away from those kind of like skills-based models of physiotherapy and more into this kind of like clinical reasoning understanding of my professional role and, trying to fully understand a person's experience. And I guess, where am I now? Well, I'm probably more lost than I was ever. I'm not really sure what pain is. I don't really know what the meaning is of pain. I'm not sure we can say that there is much of a meaning to it sometimes. Why do we, but I guess what I'm more moving into is this idea that it is, it's more than just biology. It's more than just brain processes. It's more than just one particular, neural process. Or neural mechanism. It seems to be something that we do based on all of the information that we collect over the years and that we sample in the moment. And it seems to be more about how we are in the world than telling us something accurate about the state of our individual tissues or systems. But that doesn't mean that the individual tissues and individual systems are not important in that, because that would be, I think, too big of a statement. So I guess the conflict is still there, but I'm shifting my position, I suppose, and have been on that journey for the last sort of 10 years, really. And it's a long one.
Yeah, no, and pain can definitely. I admire your response as far as I don't know what pain means at the moment, and to me, it's a sign of somebody who's a deep critical thinker and clinical reasoner, because it kind of reflects pretty the status of and state of things in pain. But it brings uncertainty, and uncertainty is one of those things that I'm sure, as you were a young physio, you wanted nothing to do with uncertainty. You wanted certainty. You had mentioned, and I remember this very similar journey of like, I need to find it and fix it and be the all-knowing person who can take this person into stress and save the day. Yet now you function in a state of uncertainty, and successfully. You're doing well with not only obviously clinically, but you coach a lot of clinicians in that uncertainty. I'd love to hear your thoughts on how you get clinicians, because you do a lot of great work coaching clinicians who are probably struggling with this uncertainty to find their footing, to be successful with people who are in this distress. I'd love to hear your approach and how you deal with it.
Yeah, gosh. Well, first of all, thank you for the compliment of saying that, you perceive that what I'm doing is successful. I think I do the best I can. And I try to always uphold my own principles of what I feel is right and proper in the way that we do things. But I think sometimes what happens is maybe people might see that as me being super successful in the clinic and always knowing how to best support someone and how to do this thing well. And it's a process, and there are often times where I get it wrong and I might overstep a line or say something that's not particularly timed well, that brings up a lot of conflict. And I guess one of the things I've done a lot of work on is in forgiving the fact that I'm human and that this other person is also human, and that we don't know everything about each other. And so there are going to be times where we step into a direction that might be particularly unpleasant or distressing for somebody else, because I can't see the whole picture. And so just one of the things I've worked on is having that little bit of humility where I just say hey, I'm really sorry. I didn't realize. And now we know that there's a boundary there. I'm paying attention to that. And I'm going to hold that as best I can. Whilst also recognizing that I am human as well, and full of flaws and make lots of mistakes and get that wrong all the time. And I think that is what helps me build sort of good relationships. Trusting relationships might be the right way, in that we trust each other enough to allow the benefit of the doubt to be there, and to allow flexibility within their relationship. And I think that's what we're looking for, really. You're never going to have the perfect relationship or the perfect conversation, but if you can trust each other, and you recognize that you're both working within the best interests of the person, and that you're authentically doing the best you can, I think there's a lot of space for uncertainty and error sometimes, and mistakes. And sometimes they can be the best conversations that come out of that. And so for me, really getting comfortable with my own fallibility and my own, humanity has helped me to build more authentic relationships that honor the complexity of the experience, and also the rich life that this person has had before they came into before our existences met. So I think that's one thing that I've spent a lot of time working on. And to be honest, it is the work that I've done with psychologists, the support, the regular supervision and coaching that I get from my psychology mentor. And also the deeper and deeper I go into something like acceptance and commitment therapy, and thinking about, what it is to be human. And that has helped me enormously to hold that space, because I think we sort of get encouraged by the model, the very simple linear model that we're given in physio school, and I don't mean that in an offensive way, because I think teaching physio is an enormously difficult task. What do you fit in? How do you guide people through this? How do you make sure people get to the end? When this is not an easy job to do, and it's not an easy topic to learn, and it really isn't something you learn in 3 years. You do need to keep investing in it for your career. So it's an enormously difficult task to do, and ultimately what happens is everything does kind of get simplified and made into a kind of linear model, because we're moving through time linearly. So we sort of build it that way. And you do get kind of caught up in this idea, well, if I ask the right questions and I move through the algorithm and I find the right answers, then I will know the cause, and then the cause will tell me what kind of treatment I need to do, and then the treatment will reduce the pain, and then the person will get better, and then I will get a box of chocolates, and we'll all move on very happy. And it's that kind of feeling. And I think one of the hardest things is when you realize, yeah, it was very nice, but it wasn't accurate. And now I have to go into learning all over again, almost as if it's from scratch, because now you've got to fill in the gaps. And that's a hard undertaking, and can come with a lot of anxiety and a lot of feeling of personal shame, like you have somehow you've got it wrong, somehow you're not good enough, somehow you just don't know what you're doing, especially when we see other people, particularly influencers, who seem to have it so. I mean, I look at these people and I think, what? Are we doing two different jobs? Like, I walk in and it's like, I have no idea who this person is and what's going on, and I'm burdened with all of those feelings of fear and anxiety as I open the door. And yet, you look on social media and it's so simple. And what I think is happening is that people are hitting that cognitive dissonance as they come out of university, and they're just like, well, I'm just going to stay over here because this is easier, or this feels like I can get more notoriety. This feels like I can push the agenda of my own ego. Which is fine and good for them, and we have a wide enough profession for everyone. But I think for me, it feels like it doesn't convey the real complexity of being human, working with humans on a very human experience that we don't really understand yet. And so I think if you feel like you don't know what you're doing, you're probably in the right area. Keep pulling on that thread and keep asking those questions, and eventually you'll realize why you feel like you don't know what you're doing, because nobody does.
Yeah. I love the discussion of, this thought of everybody, I think, views some of the folks we hear on podcasts or see on social media as they're going to walk in their clinic and all these people are just getting better. And I always say, like, if people would follow me, I don't think they're going to be amazed at, that I still have people that don't get better. There's still people that I am like, not sure what's going on, like we said, and trying to get comfortable in that space is a major undertaking. And I think you give some good examples of just some of the thoughts and the internal kind of discussions we have with ourselves, and this feeling of, inferiority and imposter syndrome that sometimes pervades even there's definitely times where I still feel it walking in the clinic and then we have this flip side of social media that presents, the highlight reels of everybody's practice. And I agree, it doesn't represent some of the challenges and the reality of what we face on day to day, because human beings come with a massive degree of complexity, and you've done an amazing job just kind of diving deep into that complexity. I want to touch a little bit about your psychology, especially some of your supervision and how you're kind of undertaking that. But I'd love to even back up a little bit to philosophy, and I know this can go deep, and philosophy is a massively deep topic. But how did that enter your world, even just the conscious thought of philosophy itself? Because I know for me, it was really bumping into folks like you and Mick and others who were talking about phenomenology and ontology and epistemology. And Matt Lowe's been another one that's stimulated my brain in that mode a bit. And honestly, I had no idea what those words meant. And as I've dug deeper, it's really made sense. And it's been really a fulfilling way to start really looking deeper to say, one, it honors the complexity of what we're dealing with, because there's just so much that informs that complexity and things that we probably don't even consciously think about that informs it. But I'd love to hear how philosophy kind of entered your world and where it sits now, and how you feel like, as somebody who might be toiling with the struggles that we speak of, that how that might be a helpful resource for people.
Yeah, I mean, without a doubt, philosophy became a part of how I understand healthcare and my practice because of the relationship that I had with Mick Thacker, who really sort of like gave me permission to go back into some of the work I had done as a journalist, thinking about social theory, power, privilege, conflict as well, and like, all of those things. And even before that, so in my A levels, so what is that, sort of 16 to 18-year-old school, I did a topic called communication studies, and we looked at communication theory, and we looked at things like Marxism and feminism and post-colonialism, and like, what are all these systems of building societies that exist and understanding societies that exist. And I think I had taken that into my journalism world, but had never really thought about what that might mean as a physio when I went into physio school. And it wasn't until I met Mick, and he was like, this is, pain is personal and public, and politic. It's not just something that's happening within your therapy room or within the houses of people who experience pain. This is, you can understand, I was talking to someone this morning who was saying, like, actually our clinic is like a microcosm of society. We're seeing social problems on a massive scale out in society, but we're also seeing them on these like micro scales within therapeutic environments and therapeutic relationships. And I think it was Mick who really sort of like gave me permission to go back to those things, and who, he's doing his work with Andy Clark, who's a philosopher of mind at the time in Edinburgh, and now I think he's down in Sussex, looking at predictive processing and the embodied mind and the extended mind. And so that's where those conversations came in. But I guess it wasn't actually until I moved to Amsterdam and was taken and was put under restrictions because my license didn't transfer. So this is where these things are important, right? Because I moved to the Netherlands, and in order to move your license from one country to another, you have to equivalate. And the equivalency process is very lengthy here. So in the meantime, I had to find a way to still be connected to my world and my environment. And I was already teaching. So then I started thinking more deeply about some of the questions that I'd had around philosophy and around, social theory and power and discrimination. And, over the years, I've been able to meet more and more philosophers. And I think if I hadn't have been put under restrictions and then had to find a new way of understanding my profession and think more widely, and had the space to think more widely, I probably wouldn't have had the time to do that, because clinical time doesn't, the clinical system, the framework of that is not designed to give clinicians space to think. It's designed to get people through a system, which means clinicians are often running very high volume clinics with lots of complexity, and, having a space to go and read a philosophical paper might not be something that is available to us all when we're in those high volume clinics. And so that's how I ended up in thinking about philosophy. And then once I opened the door, I was like, oh my God, this feels really important and exciting, right? This is changing how I view myself. This is, and how I view practice and how I understand pain and how I understand, it's starting to help me make sense of some of the really challenging, personally challenging experiences that I've had in the clinic. And it's really empowering the model I have, the psychotherapeutic framework that I work within, because it seems to fit very nicely within there. So then I started exploring the philosophy of acceptance and commitment therapy more, thinking about, the functional contextualism and how the environment might afford a certain type of experience. And that links very nicely with an activism and embodied cognition. And so we're starting to see, I just sort of started to see how these worlds were all coming together, which was very exciting and rewarding.
The psychology background that you bring to the table with how you've really pursued that, obviously, as you read the literature and what we see out there in the physio landscape, psychologically informed care has been a big push.
Mm-hmm.
But in to talk about it's one thing, but to truly enact it and truly incorporate it into practice can be another thing. I think sometimes it gets lip service, and then there's not a lot of depth to true application. But you've obviously gone deeper and went into true application where you're working with a psychologist who's giving you feedback and mentoring and things. I'd love to hear kind of your perspective on where we are in that whole psychologically informed approach and where you think, best practice sits. Obviously, there's some subjectivity to that, but I would definitely consider you someone who is an expert in the incorporation of psychological principles into what we do. I'd love to hear your thoughts on where we're at with that and kind of how you use it in your practice and get that kind of guidance.
Yeah. Oh, wow. Well, first of all, thank you for that. That's very kind to say. I still, the sort of, I suppose the rookie identity that I still hold on to sometimes would say I'm nowhere near an expert, but yeah, I do call myself a consultant in psychologically informed physio. I am at that place now where I feel like, the role I take on very often is advisory, it's facilitatory, and it's teaching. But there is always just so much to learn. And one of the things I love about having a psychology mentor or supervisor is that she reminds me just how much I don't know. And that's just a wonderful, humbling experience. And, realizing that, it's not about necessarily doing it right or doing it well. It's just about kind of understanding and appreciating that the way a person feels, the thoughts that they have, this internal experience that is private to them is so much bigger than we, as observers could ever know, because ours is so much bigger than other observers can ever know of us. And so what we're trying to do with psychologically informed physio is just try and move towards honoring that and recognizing that, pain, if we're saying pain, if we're saying pain is not nociception, it's not just a product of tissue injury, then, and even if it was, that just, if we're saying it's not just a biological process, that we're just saying it's more than sensation, it's an experience, then as clinicians working with the experience of pain, we probably are required, I would say, by our evidence-based ethics to be incorporating more and more of these approaches. And actually, psychologically informed physio isn't anything new. The earliest mention of psychologically informed physio goes back to the 90s with, physiotherapist Vicky Harding and psychologist Amanda Williams working out of UCL and St Thomas's in London, where I was fortunate enough to do some work under the department that Vicky used to work in. This is, and then we go back to sort of the 2000s, the mid 2010, 11. I think there was a paper that came out. I think it was the George and Lamb paper that was like, we are now at a place in our evidence which says if you are a physiotherapist and you are not engaging in psychotherapeutic models, you're not developing your psychotherapeutic approach to integrate into physio, then you're no longer evidence-based when it comes to pain. The evidence now requires us to do this. And yet here we are in 2023, still talking about it like it's this new thing that's just arrived recently. And that's partly because, like you say, how do we fully integrate this into a model and a framework that was built and predicated upon the idea that pain is something that happens to people because of some kind of injury and is correlatable to that injury, and therefore we have a role in some kind of tissue change, and then that would go away, which doesn't necessarily mean, shoulders don't talk about their feelings. So if we're thinking about shoulders and we're not thinking about people, then the system that we build around that will not necessarily privilege and prioritize the time and space and environment that people need to talk about their pain. And so psychologically informed physio just feels like a no-brainer to me. It seems so obvious that we would be engaging in this, but yet at the same time, so difficult for clinicians and myself, working in traditional models and against traditional timeframes with supervisors and colleagues and mentors and managers who don't necessarily acknowledge that psychologically informed physio or a physiotherapy practice that looks to incorporate the experience of pain into how we formulate somebody's, I suppose, diagnosis and prognosis, takes a lot more time, and that can be hard on an individual clinician that is dedicated to integrating these things into their practice. And I suppose when I think about it, I think, well, how much time has it taken me to figure out what this thing is and what these things look like? Well, I remember my very first mindfulness-based stress reduction program was like, it must be one or 2 years after graduating, so 10 years ago. And, I had an idea as to how I thought it would be integrated, but I didn't have a lot of people to talk about it. I was in MSK clinics and people were kind of just, oh, you do those patients. And I was sort of put in a corner of the clinic, and people didn't really ask too many questions because they didn't want to know what was happening. And, it wasn't until I started finding really good supervisors who were like, yeah, let's see how we can develop your practice and let's see how we can take you further, and who protected me from the model, if I'm really honest, and said, yep, if you need 3 hours, take 3 hours, I'll protect you. That I was able to really expand and be creative and make mistakes and rebuild and try again. And then I went into the tertiary centre where I was working with Prof. Lance McCracken, and I had a psychology supervisor, and I was embedded within that, and I was like, oh, I see where this is. Actually, it needs to come from the moment the person walks through the door. We need to be thinking in terms of, what it's like to be human, and what is it like to be me as a human, and how do I make space for all of that, and how do I manage my own responses and my own, urges to act from a place of emotion to what this person who's experiencing pain is saying to me. And be able to sort of put that to one side and be able to center them within that experience. And so psychologically informed physio is not a new concept. It's a very old concept. It's been very well developed and very well thought out in many ways. And there's lots of resources there. Physios can go on psychology courses. There's nothing to stop you from going on a psychotherapy course or going to an ACT course. But the thing that I see most often when I work with individuals is, but how does this fit into my practice? How does this fit into a traditional MSK space? And that's very difficult, because now we're talking about identity and systems. So we're talking about power, privilege, discrimination, and all of those things that we all experience. But perhaps, if you're living within the dominant group, say you're a cis, hetero, white, middle class, you might not necessarily have experienced power and privilege in that way until you start stepping outside of the box. And then all of a sudden you become very aware of it. And I think having some humility in terms of recognizing that this has always been going on. This is a part of how our system is built. And then realizing that if you are moving towards pain care that is recognizing the whole person, you're working within a social justice space. And so you better fill in those gaps pretty quickly.
Yeah. I think just that deep look at what we're up to and some of the things that inform them, some of the, like you said, power structures and social kind of structures that we, again, I know I personally didn't even consider it. I was just so unsteady. When you come out of school, you're just trying to figure out what's going on and get your feet planted somewhat firmly on the ground to feel like you're not failing from a day-to-day thing. But as you're a great example of somebody whose journey who, continues to just realize that humans are never going to give us stability to where we have this like approach that is this just algorithmic linear approach that works with most of the folks that work through the door. And I think you also bring up some great thoughts on this psychologically informed thing isn't new. This is something we've been talking about for some time, and it gets frustrating because you see the time from research study to clinical floor, but then even more into university classrooms can even be longer. So we still have a ways to go with that, but folks like yourself definitely pushing that a bit in a good direction. So much appreciated.
And I'd say that probably we're always psychologically informed. When you think about the influence of cognitive and behavioral therapy over the years, this is an approach to understanding the mind and how people experience the world and emotions. This is something that comes out of like the early 1900s. So it's very reasonable and plausible to think that physiotherapy has always been psychologically informed. It's been informed by the movement of cognitive and behavioral therapy. Always. It's just that cognitive and behavioral therapy has also gone through its own evolutions and changes. And we're now moving, we've been in sort of like where we had behaviorism and psychoanalysis. And then we had, then these two worlds came together to become like cognitive and behavioral therapy. And then we had third wave behavioral therapy, which was the beginning of the acceptance and commitment therapy movement, compassion focused therapy. This was sort of the last 10, 15 years. And now we're maybe moving into another phase where we're thinking about process-based therapies. And, it's also evolving all the time. And so now I think what's happening is physios are like, oh, this physio model that we have doesn't fit with this new emergence of psychotherapy, this new evolution in psychotherapy. Now we need to go into psychologically informed physio. But actually, we're just updating the model through which we are psychologically informed. Maybe we're becoming a bit more aware of it and a bit more cognizant of the influence on physiotherapy. If you think about it's very likely that we've been working within cognitive and behavioral frameworks for a long time. It's in pop culture, it's in pop psychology culture. But now we're just a little bit more aware of it, perhaps, and trying to think, well, how do we do that? If we do that intentionally, are we better at it? And the evidence tells us that physiotherapists, if they do that intentionally, they are better at it, and it helps them to build more relationships, and it helps them to it helps them with engagement. People tend to stay on physio longer. They tend to do more. It helps us to manage our own well-being. We start to have less anxiety. We're perhaps less tendencies towards perfectionism. These are all really good signs that says, being more intentional about your learning and integration of psychological approaches and theory into your physiotherapy practice, which will be personal to you as well as, translatable across people, can not only help you to hold a safer space and a more therapeutic space for people with pain, but it can also help you within your own personal experiences of being a therapist, which is not easy,
Yeah. No, I would wholeheartedly agree. I would testify to that as far as incorporation of psychologically informed care has really made me have more comfort in my ability to not always have the answer, to not always be that person who needs to have the cure, the fix, and things, and being able to hold that space with still having confidence that I can do my best to help somebody, but also not carry this massive burden of the outcome on my shoulders to where I have to have this outcome that comes out. I'm going to do my best to have the best co-created space and outcome I can have with each person, but I also honor the fact that I can only do so much. And there's also so many things that inform, that interaction with a person that, you do your best. And there's sometimes it may not come out in the best, but we can always be confident that we're doing our best to come together with somebody and make the best outcome possible. But there may be things beyond our control that may impact those things. So I really appreciate your thoughts there. The acceptance and commitment therapy you've touched upon already, and that's been one topic that you've been a big influence on myself as far as really incorporating it better into my practice. You've done a masterclass for us in the past. We'll link it in the show notes here. But you're also doing some more things on the ACT front. But before we get into your course, because I'd highly recommend if you want to learn how to incorporate it, Laura's probably the best person to do so to help you in your practice. But I'd love to hear kind of your view of acceptance and commitment therapy, how it's kind of where you came across it. You've already touched upon it maybe a little bit, and how you kind of look, big picture principles that have helped you better navigate your clinical world.
Yeah, acceptance and commitment therapy is what's called a third wave cognitive and behavioral therapy. So it focuses less on challenging maladaptive thoughts and beliefs and avoiding triggers, and more on, how to live well alongside adversity. It acknowledges that adversity may well be a part of somebody's life for longer or shorter periods of time, and that we all experience that. We all go through these periods of distress and difficulty. And so it's about figuring out how to live well alongside those things, rather than get caught up in the struggle of trying to get rid of them in order to move on with your life. So it can be particularly difficult. It's not specifically about pain. It's not a pain-focused psychotherapy. We're not necessarily even focusing on trying to reduce pain, although I would hold that pain reduction is always something that I'm, wanting to achieve, because I feel like as a healthcare clinician, I'm committed to, doing my bit to, help people, not necessarily help people, but, hold a space for people to experience positive change. I think that's the therapeutic contract that we kind of, we're here to support people in the changes that they want to make in their lives, and we do the best that we can to be part of that in a positive and helpful way. But ACT in itself isn't necessarily concerned with changing pain. In fact, it quite explicitly says this is not about, measuring reduction in distress. This is about, working in ways to make life richer and bigger, and doing things differently in order to make life richer and bigger alongside some of these experiences. So I guess what it's helped me with enormously is, when pain doesn't necessarily change, rather than chasing the change in the pain, which can sometimes lead to stigmatizing or dismissal or over-medicalization, because then all of a sudden we're concerned or frightened that something is more seriously wrong, when all of our evidence says this is not necessarily anything sinister or specific. So this is something general and non-specific, or primary, like a chronic primary pain. Then it sort of allows space for us to be like, okay, we're going to hold pain reduction just here lightly, because obviously that's part of human nature, right? We want better experiences on the world, but we're going to work towards, this thing that we call, life. What is your life? What are your values? Where is your joy? Where is your feeling of, having a role in society and being content and doing the things that are important to you and getting your necessary stuff done, even when some of that isn't particularly fun, or when it might come with pain. So it's opened up that part of my practice that wasn't completely dependent on pain reduction as being the only outcome for a good therapeutic experience. And that's really quite explicit within ACT. And it teaches us skills. And it teaches, I think certainly the way I teach it is ACT is not a thing we do to people. It's a part of how we understand, what it is to be a person that experiences negative and unpleasant emotions and sensations or perceptions, or stuff happens. Life is sometimes very hard, and so how do I best navigate that? And thinking about the framework of ACT gives us these sub processes to focus on, like and recognizing if you're spending a lot of time in the past or a lot of time in the future, and just, coming back down to the present moment to remember that what we can do right here and now it's really all we can actually control. That's really all we can do from moment to moment. I can't change what's happened in the past, and I can't ensure something is going to happen in the future. The only thing I can do is this moment, this choice, this breath, this me, this here. And one of the ways that we can start thinking about, well, what choices do I have in this moment, is by being willing to accept that this unpleasant thing is here and I can't necessarily change it. So I'm going to allow that to be here. And then I'm going to observe what urges, what habits, what rules, what actions seem to be, do I seem to be moving towards, that I feel like I must, like I feel like, we call it stimulus equivalence. So I have this unpleasant experience and then I want to do this action. And that might be, I have pain and I want to run away, or I want to get away from it, or I want to find out what the cause is. And so, by spending time in the moment and accepting that pain is here, we might not be able to change it. What space does that give me to make a different decision? And if I've got that space, if I can take that diffusion, if I can take that step back, what do I want? What do I want to move towards? Who am I in the world? And thinking about, your values is very important, but also yourself as a context. Like, what is the trajectory you're moving towards? What stamp do you want to put on the world? And what actions are in line with that, rather than what is this sort of response, this response to this unpleasant experience? What action is responding to that unpleasant experience? And if you have the choice, even though it's not easy, and even though you might not be able to do it to 100% of what you have idealized in your head, what would you do? Yeah, what step would you take? And that might be a small step, but a small step in the direction that is meaningful to you can often feel like a small step well spent.
Yeah. No, well said. I'd love to hear, because I know you do some work with some clinicians on this, and obviously do some skilled work to help clinicians start incorporating this into their practice, because it is a journey, and having someone who can mentor you and kind of give you feedback and talk about cases and what you're seeing in real time. Because there's one thing about, having maybe some recorded lectures. Those are good. Nothing wrong with those at all. But having the ability to kind of communicate with somebody who's kind of been through it, who's, working to navigate the struggles of human pain and the things that we see enter our clinic doors. Could you share with everybody a little bit about the course you have on ACT? Because I think it's a great resource for folks that are really, truly trying to incorporate, not just, again, watch them record things and maybe not get that true application and staring ourselves in the mirror of what we're doing in the clinic.
Yeah, so I've been developing this online course. I mean, I started teaching it just before the pandemic restrictions were put in place. Excuse me. But then, and so essentially what it is it's a 4-week course. We meet up once a week and we move through discussions about elements of acceptance and commitment therapy that are useful, and we practice some skills and we think about what this might mean for your practice. And we spend a lot of time thinking about the framework and about the kind of like, what does the framework actually mean? Like when we think about acceptance, like what actually does that mean? It's very easy to just reel off. Acceptance is the ability, the willingness to have unpleasant experiences, right? Okay, that's a sentence. What does that feel like? How easy is it to do that? How are you going to support somebody to be willing to accept the unpleasantness of pain in a clinical space? Because that's what that sub-process is all about. It's not just telling people, oh, now you just need to be willing to accept that pain is a part of your life. Like that, I mean, people are rightly angry. Patients are rightly angry when they feel that that's what's being said to them. Because that's not what we're saying. We're saying, how do we get closer to being able to have this really unpleasant experience of pain and also be able to move towards the things that are important and valuable to you in your life? And that in itself is a very hard, challenging process. And so when we start incorporating acceptance and commitment therapy into physiotherapy practice, I think what we have to remember as teachers and as facilitators is that physios haven't done a 5-year psychology degree. they haven't spent time thinking about, why am I a clinician? Who did I come into healthcare to fix? What ills in the world did I feel like I wanted? I mean, I know that I had to do some work in realizing that I could not fix my mother who had chronic pain when I was younger. I could not get that back. I had to go through the pain of realizing that although that might be part of the motivating factors for me to become a clinician, it's got nothing to do with what I do as a clinician now. And it really needs to be bracketed away from my clinical environment. And these are really hard things for a clinician to go through. And, psychologists do a lot of work around different models. They learn all the different psychotherapeutic approaches. But a physiotherapist going onto an ACT course doesn't have necessarily all of that background. And so when you say to a physio that doesn't have a psychological background or hasn't necessarily been through these processes of knowing themselves and their own personal development, process 2 is, process 1 is mindfulness. Process 2 is acceptance. Process 3 is diffusion. Process 4 is self as a context. Process 5 is values. And process 6 is the end, committed action, and it's like, we take that very literally sometimes. And we might think that it's as simple as just, saying, okay, but, pain is there, but now what? Like that, this is not it. Acceptance and commitment therapy is a full psychological model with a philosophy and with a mindset and a personal practice that is expected of the therapist that is holding that space. And so when I teach my course, I try, I do the best I can to honor the fact that we also need to fill in some of those gaps and leave a space for clinicians to question themselves and experience their own conflicts. And actually, that's exactly what we focus on. So instead of thinking about how do we use ACT to help people with pain, on my course, what we do is we think, well, look, this is ACT. What does it mean to you? What are you experiencing? What struggles do you find that you're coming up with? Okay, here's a technique in ACT that might help you to find some distance from it and to make choices. What does that process feel like for you? How do you go about that? And how do you take that experience into your next clinical experience whilst being underpinned by the theory? So we're drawing on our own personal experiences. We're humanizing ourselves within this process in order to hold the humanity of the other person when we go into the next session, rather than just being told, this is a list of all the things that you do. So that's how I build this course. And, that's why I think that 4 weeks is nice, because we meet every week, we build it up gradually. And then we go into a coaching period after that, where people come back and we talk about it and we sort of problem solve some of those experiences, just to help people integrate it. Because this is not a weekend course and off you go, now you know how to do it. This is a fundamental shift. It's a paradigm shift within how you understand your role and how you hold a space for other people. So that's the course that I do. And then, of course, that is then I, hold this individual clinical coaching space for people who maybe want to take that further, or people who want to further specialize in pain informed and rehabilitation spaces. And it's not just physios that I work with there. On my books right now, I have exercise physiologists, osteopaths, chiropractors, physiotherapists, gynecologists. It's a really, I tend to work mostly with people who are applying their profession in a body situated way, to understand how to integrate across these different approaches. And then what I'm really happy about, and what I love doing as well, is I have a small subscription which allows people to come in for if you either you can't access those things, or you've accessed them and now you just want ongoing support, or you just want you want a place to keep coming and bring in complex cases. So it's there's 2 hours a month of people can just drop in and bring their complex cases or questions, and we can have this hour-long conversation about it. And it's and that, as well as other resources that I've built up on there, that I think just help people in that sort of more long-term model of of working in this space. Because, you know, Mark, you probably have this as well, but so often I meet people who are super dedicated and committed to understanding pain and holding this space in a whole person way, better, right? Better ways for people that is more compassionate and more honouring of the humanity of what it is to be a person with pain. But they're like the only person in an entire department, maybe even in their entire area. Like they might not know anybody else doing this kind of work. And so the feeling of being very isolated and being very lonely and feeling wrong somehow, or like out of step, or like, you know, unsure. I mean, I've got stories of clinicians hiding their practice from other members of their team, you know, taking patients into the back of the gym because they want to talk about feelings with them. You know, this is such it feels like such a toxic environment for emotionally minded physiotherapists to be working in. And so I hold this space for people to just come and have, you know, the supervision that they need actually in order to continue that practice and to feel like they are growing within their appreciation of the full experience of pain as per the current definition of pain, that it is, you know, a physical and emotional experience every time, not just in chronic pain, all experiences of pain. And so, you know, one of the things that I know has helped me not be good at this, right? That's not what I'm talking about here, but has helped me to maintain my well-being, safeguard my mental health, prioritize my own personal and professional development, have safe boundaries, reach out and be in the room of people who are experts in this field, who are doing this research. You know, the thing that really made that possible was good support and supervision. And I remember it well. I remember taking this job, and Elaine, she'll not want me to name her, I don't think, but I love her to bits. But she just was like, I don't really know what you do, but it seems like it's the way we need to be going as clinicians. Do it and I will have your back. And that was like, that's what we need. Because it's not just a paradigm shift. It's not just about information. It's about feeling safe as a clinician to try and to explore and to get it wrong and to, you know, as we move into these new ways of practicing. And that is going to require more than just, you know, a weekend course. That's going to require system change. And so we're all called to action. And now what you see all around the world actually is healthcare clinicians taking action and demanding, you know, better systems, better environments, more financial safety in order to do the work that they do, which is important and meaningful. And I strongly hold by this statement that, you know, physiotherapists, as with all allied health therapists, play an important role in the lives of many people who are living with disability, illness, long-term conditions and pain. And so we should protect that, I think. Yeah.
I mean, you can just hear in your answer the depth you go and the passion you have for the topic. So, I mean, those are the type of teachers that I think we need in the world to help kind of get these principles incorporated in the practice. And I would definitively agree that, you know, the clinical communities that you create with clinicians who may feel very isolated, very alone, that is so rewarding and so kind of comforting when you're in that instability to know that there are other people in the world who may feel like they have to hide their patients in the back of the gym or go to a private room because they're afraid what their colleagues are going to hear about talking about feelings, and they're going to have these negative judgments of them. So I think having that opportunity to be in a group of like-minded clinicians who are facing the same struggles, like that is so powerful and rewarding. Yeah. Having had it happen and have the ability to have that in the past, I'd highly recommend y'all think about getting involved in that course if you're looking to see how this fits in your world and get better at this. The research and science has long since been there. Yeah. That these are processes we need to incorporate into our practice. So definitely take a look at. We'll link it in the show notes. Laura's course and where you can kind of get to contact her. But
come and join me.
For those, absolutely. For those of you who may not watch the show or read the show notes or anything, Laura, if you could just let folks know where they can kind of get a hold of you, where they can reach you.
Yeah.
And then we'll wrap up.
Absolutely. Like, you can get almost all of the information. Well, I'm hoping all of the information since I write the website. But like on my website, which is laurarathbone.com. And also just to give a shout out to another community that I run with my partner in sort of my partner in Pain Geeks, Christine Petrudis. We run Pain Geeks, and you can find that on paingeeks.community, and that is a reading group that really focuses on, how we read, what we read, and and what does this mean to us as clinicians in our practice. So we integrate humanities as well as basic science and social science. So just to say that those things are available, and also, everybody is welcome in the spaces that I hold. You don't have to be an allied health therapist. You don't have to be a physiotherapist. This is about people who are working to support people with pain, wanting to understand pain more. And so for me, that includes all professions. That's, everybody's welcome. Come, join.
Yeah, again, I'd highly recommend it. Definitely check it out. We'll have those links in the show notes. And Laura, I want to thank you for your time today. I really appreciate the conversation. Always enjoy chatting with you as far as what you're doing, and very impressive stuff that you're doing. So keep it up.
Thank you very much. It's always lovely to be here, Mark. And thank you for inviting me on again.
Absolutely. We'll have to have you on in the future again. Yay! And hear how your journey, our journeys continue to unfold, and more conflicts will occur that we're having to navigate that.
Oh, yes.
I think are valuable for our listening audience to hear and see that some of the struggles are not unique to them, that we all deal with some of this uncertainty and conflicts in our world and in our practice. And you're a good example of somebody who's navigating it and really putting it out there and helping others navigate their own struggles. So thank you for that.
Yeah, I think if I could say one more thing, and I know that we're coming to the end, and I know I talk a lot, but I think what sometimes happens is when we talk, and what I've heard a lot of clinicians say is, well, if nothing matters, then why do I do the job I'm doing? And I just want to end on a note that says, what we're saying in the evidence is not that nothing works. It's that everything probably has the potential to work. And so your job is really important. And the time that you invest into developing your knowledge and nurturing your interpretation of the evidence and growing a wide practice that has enough skills and space for the human experience of pain, that is really important. And what we do makes a difference to the people that we work with. And I think this is a really valuable message that sometimes hasn't necessarily come across. And it's what I hear quite commonly is people just feel like, I don't even know why I'm doing this. And I would just say that, thank you to every clinician out there that listens to the podcast, that gives their time, that invests in the pain-informed communities, because they do not typically survive more than about 5 to 6 years, right? This is the sad thing about the job we do, if we look at the pain-informed communities, certainly since I've graduated, I've seen them come and go. But for all of the clinicians that do continue to invest in these spaces and to engage with them and to promote them, thank you so much, because this is not an easy space to be in. Pain is not an easy area to work in. And the work that you do, supporting and investing and learning, matters. So thank you.
Yeah, no, definitely would concur with your thoughts there. It is a tough journey, but there is a lot to be had. I know there's a lot of sometimes cynicism and nihilism about what we're able to do and not do, but there is so much opportunity and so much opportunity for growth for clinicians to really find comfort in the discomfort and the uncertainty and the distressing situations we find ourselves in the clinic. I actually have renewed my enjoyment for clinic. And there was times where, especially when I was in the depths of my manual therapy pursuits, realizing that the complexity chase I had there didn't really pan out the way I was hoping it did. But then really getting in and chatting with folks like Laura and getting to talk with Mick Thackers and have Matt Lowe's and have, Chad Cooks and other folks, they've really had huge impacts on myself. Yeah, Bronnie Thompson. I mean, we could probably list off,
She's my soul sister. I think she's a wonderful human being and a brilliant researcher and guide and teacher as well. So yeah, read her blog.
Very, very much so. Yeah, and she'll be somebody who will be reaching out again. Bronnie was on, one of our early episodes when I was still figuring this thing out. So we'll have to have her on for another conversation. But well, I want to respect your time today, Laura. I really appreciate it. Yeah. We'll definitely have to chat with you in the future. Yeah, thank you very much, and thanks for letting me take a very extended goodbye. Oh, no problems. We appreciate it. We appreciate your time today. And we appreciate all you who are listening and who have made it this far. Obviously, some great stuff today, and really appreciate you. If you could pop on and maybe subscribe on the podcast vendors or maybe even on YouTube, we'd greatly appreciate it so Laura and I can get our message out to more folks. Absolutely. But until next time, we'll talk to you all next episode. Bye.